Good morning, everybody online. We're gonna give it just a few more minutes. Gonna have to change some things up. Dr. Nasser was gonna go first because he needed to be done by a certain amount of time. Actually, he now has an emergency, so I'm probably gonna be doing the same report, and then we'll move from there. We may have to bounce around a little bit.
Yeah, I know. I could always turn out if I don't. It's not. Yeah.
All right, guys, good morning. We're going to get started. It's a little after 9. Welcome to EMS Honor Review, Union Hospital, April 11th. Brenda is not feeling well at home today, so I'm going to do the STEM report for her. Normally, we had it set up where Dr. Nasser was going to go first, but he's got emergency cath, so I'm going to go ahead and do this STEM report. All right. So, EMS is dispatched at 11:03, 911 for a 61-year-old with possible heart attack. All right, so 11:09, they arrived with the patient to find a female sitting on the couch within a residence. Patient has her shirt up around her shoulders, bra straps down around her arm. Patient stated that she just returned home from the doctor's appointment. Hemorrhoids. Yeah, wow. States she had a cup of coffee, and then while taking her bra off, she started experiencing chest pain. With pain radiating into her left arm that has slowly radiated to her wrist. Rates of pain 12 out of 10. That's pretty close. Due to weakness, patient is unable to ambulate. Pale in color, notably just diaphoretic. Unsure of her allergies, but states that she has a list in her purse. Patient states she took 3 adult aspirin prior to EMS arrival in tablet for 325 milligrams. History of hypertension and hemorrhoids. Used chair to assist the patient to the ambulance. 11:17 assessment of vital signs obtained as shown on the paper there. 111/72. Heart rate is 65. Respirations are 26 and 96% numeric. 11:19 12 lead non-STEMI inferior ischemia. 11:20 18 gauge left forearm with normal saline running wide open. 11:27 second set of vital signs 125/78, heart rate of 45. Respirations are 22, 100 on 2 liters. Blood sugar of 153, nitrostat totaling 0.4 milligrams was given. Oh, and we're done. I want to say thanks for everybody for showing up. Goodness gracious, it's the second time that has happened. At 11:32, 12 lead EKG STEMI inferior ischemia with elevation 2-3 AVF with reciprocal changes in 1 and AVL. 11:33 patient now stating pain is 8 out of 10, but severe. Her left arm radiating into her jaw. Nitro 0.4 milligrams sublingual administered. Again, radio report given to IU via IHERS. At 11:39, they arrived at Union. Patient transferred to trauma 3. 11:47, phone call with cardiologist regarding patient's plan of care, accepts patient for cath lab. 12:15, patient arrived in the procedure room. 31, balloon catheter advanced to target vessel, stent advanced to target vessel. Drug-eluting stent was placement at the distal right coronary artery, reducing 100% thrombolytic occlusion to 0. Patient transferred to ICU, discharged the next day. Door to balloon time was 52 minutes. Pretty good time. Looks like January, we were only at 75%, which is pretty low for what we normally do for door to balloon for 90 minutes. So we will probably, for that number will eventually get up when we start going through. I haven't seen February and March's data yet, so we'll get that. Beth, would you like to do your stroke report?
Sure.
All right, great. Appreciate it. Beth Harrison's going to do the stroke report now, and then we'll probably bounce back around again some more. So appreciate it.
Good morning, everybody.
I would use this arrow. That doesn't happen again.
You know, I'm not saying don't mess it up.
Yeah, don't touch that one. Yeah.
For this stroke run, this is the patient information. This was an 80-year-old female who had no significant cardiac or neurological history. Her only prior medical history was hypertension, hypothyroid, lumbar spondylosis, and she lived independently with her husband in the North End of Terre Haute, and she was independent with all activities of daily living. She was a very healthy 80-year-old. History of this, she was at home. EMS was called at 13:08 for patient complaints of right-sided weakness. Dispatch was notified at 13:09, unit 13:09:59, and route at 13:10, on scene at 13:22, and arrived at patient at 13:24. On arrival, EMS found the patient sitting at the chair at the kitchen table, alert and oriented ×3. Her family stated that for an hour prior, she was unable to move her right side at all. But when they got there, her arms, they were so weak that she couldn't move them. By the time EMS arrived, she was back to baseline, and she hadn't called when she was having the episode because she didn't want to bother anyone. EMS went ahead and worked her up for stroke, even though the symptoms were resolved. Her pressure was 170 over 81, respirators 16, pulse 96, SAT was good, Glasgow coma scale was 15, Cincinnati pre-hospital stroke scale was negative. Her only complaint was a persistent headache. They did go ahead, EMS did, and called a stroke alert to Union ER, and they called it a TIA. Went ahead and brought her in. Patient was able to get up from the chair, put herself on the cart, walk to it, and when she got to the corner, she was able to walk to the cart here at Union. They left the scene at 13:36, arrived at Union at 13:51, and she did walk to that cart. NIH was 0 at 1400 here at Union. Patient was at baseline, and her only complaint was a diffuse persistent headache. So, they're working her up. We didn't call her a stroke one because we really didn't think she was a TPA candidate because her symptoms were resolved. They were just going to do a TIA workup and probably send this lady home. At 14:30, the nurse was called to the room. The patient was totally flaccid on the right side. She had left gaze deviation, lethargic but arousable, totally aphasic. Her NIH now was 14, and a stroke alert 1 was called. 13:43, CT of the head was completed. No bleed was present. Teleneuro was consulted, and TNK was recommended. I don't know if you knew that, but back in January, Union left. We don't no longer use TPA. We moved to TNK, which is tenecteplase. If you've been in the business for a long time, we used to get tenecteplase for MIs. Now it's kind of become commonplace that we're using it for strokes. It is cheaper, and it seems to work better. The results with TNK are better at a large vessel occlusion than TPA is. So we're having some good luck with it. At 15:04, tenecteplase was given, and she was at 22-minute from symptom onset in the ER to needle time. And that was the first time we'd used TNK in our ER. At 15:21, we did a CTA. And that showed the left internal carotid with a 99% stenosis of the left carotid bulb with a huge thrombus right in the proximal left internal carotid artery. So she blocked off her left carotid. And she probably did have a TIA on the scene. She probably threw a few little clots. And then symptoms resolved, and then she came to ER and had the big one. After her tenecteplase was given, her symptoms did improve to an NIH score of 8. The patient continued to exhibit right-sided weakness, moderate expressive aphasia, and difficulty following complex commands, and she had left gaze deviation, but she was able to move the right foot. Left gaze deviation, you always think the stroke, gaze deviates towards the stroke. So she had left gaze deviation, left carotid, so her symptoms were on her right. At 1715, the MRI was complete, and it did show a stroke, scattered areas of acute ischemia involving the left occipital and the right high frontal lobe, likely a showering ischemic event. So what she had, some of the pieces of that clot broke off, showered to that left occipital region of her brain. They did consult a neurointerventionalist in surgery at Ascension St. Vincent's, and they did accept her as a patient. And at 1750, just prior to the arrival of EMS transport, she started complaining of a worsening headache. So we did an immediate CT to see if she had a bleed secondary to the tenecteplase. She did not at that time. That was negative for hemorrhage. So we did send her to St. Vincent via ground transport for a carotid stent versus an endarterectomy, which, you know, that's spelled wrong. Great. And this lady, we did send her to St. Vincent's. She did have surgery. She did not have the greatest outcomes, but she is back in Terre Haute. She's had rehab and she is living independently again with her spouse. But she did have a huge stroke from this, ended up with a large stroke, a lot of symptoms. You know, it's a really good thing. EMS did a good job. They didn't listen to her. They went ahead and brought her in. You know, it's like, yeah, you know, your symptoms are resolved now, but we need to check you out, go ahead and bring you in. They went ahead and did the full workup. The ER was doing the full workup too. You know, if they had left her home with this huge stroke, she probably would have died because she was going to be the only one there. So I think it was a really good job by EMS to go ahead and bring her in. And, you know, it's kind of an unusual case, but it was, I think, the documentation on this case was amazing. EMS did a great job documenting on this, this run. So good job.
Question for you. The
Yes.
scale that you're talking about, she went from 0 to 14 to 8. What higher the number, the worse the
Higher
score?
the number, the worse it is.
Okay.
If you get up to an NIH, the high teens to 20s, you're probably looking at a nursing home for the rest of your
I
life.
see. Okay.
Usually 2 to 3, you go home from here. 4, you get to 4 to 5, we're sending you to rehab. If you get to 14, 20, you're probably looking at nursing home,
Okay.
or at least a long-term rehab.
All right.
So she had pretty
I was trying to put
severe
them-
stroke. Yeah,
Context into the number for.
you know, you can go all the way up to like 40 with an NIH, but I've never seen one go that high.
Okay.
Usually when I get in the 20s, it's a profound stroke.
I see. Okay.
Any questions for me?
Thank you, Beth.
Thank you.
Appreciate it very much.
Mhm.
All right. Will, you ready? Yep. All right. Will Osey from Union Clinton's going to present a couple of cases, I believe.
Yep, got one Park County run, one Ileana run. There, very good.
All right, thanks.
All right, so our first case study, we have a 33-year-old female. She was brought in, history, anxiety, depression, iron deficiency, history of C-section. Her husband had called 911 for altered mental status and left arm weakness. EMS notified at 12:16, arrived 12:20, departed the scene at 12:39, and arrived at Union Clinton at 12:44. Report, they arrived on scene, presented with a 33-year-old female, Thornton Oriented ×2, sitting on her couch. Patient had left-sided facial droop, left arm weakness, abnormal function had started 45 minutes prior to their arrival on scene. Patient had been complaining of a headache the night before, but felt okay going to bed. They did do a Cincinnati stroke assessment in the field, was positive in all categories. Patient's pupils were below non-reactive, was able to follow commands, was unable to follow commands looking to her left side. Patient was able to stand, take a few steps onto the stretcher, and was brought to Union Clinton. Stroke 1 was activated off of the EMS report, 12:45. They arrived at 12:46, taken directly to CT for a non-con to the head at 12:47. Patient was unable to lay still, and her mental status declined as her ER stay extended. So she did have to be held in the CT scanner. And whichever staff member it was that held the head forgot to take a ring off of their hand, which caused really heavy artifact. So we did have to take the patient back to CT for repeat imaging, which unfortunately was a delay. Teleneuro done at 13:21, and TNK, this was also our first case, time not as good, at 13:45, which is 59 minutes door to you. Patient was eventually transferred to St. Vincent's Indy at 5 o'clock. So again, we had a big time delay, having to take the patient back over for CT, unfortunately. They had the Cincinnati stroke scale charted in the field, which was excellent, and I like seeing the ER team activate off of the EMS report coming in. Our second case is a 57-year-old male, history of asthma, CHF, hypertension, called 911 with chest pain for the last 2 hours. Notified at 1:49 a.m., arrived on scene at 2, departed at 2:16, and arrived here at Union Hospital Terre Haute at 2:37. So they were dispatched to the residence of a 57-year-old, chief complaint, chest pain, found lying in bed, ANO times 4, Glasgow coma 15, cool, slightly clammy, had been experiencing consistent chest pain for the past 2 hours. Had been at the hospital 2 weeks prior, diagnosed with pneumonia, AKI, CHF. They attempted to do a 12 lead there on the residence, but due to a lot of chest pain, we're not able to get that done. So they ended up doing one of the truck. That showed elevations in 2-3 AVF, V4, V5, V6. They did grab a right-sided EKG to confirm right ventricular involvement, which was the case. They also did a good catch in their EMR, noticed that he was prescribed erectile dysfunction medications. So they did verify last dose prior to doing any other nitrates. Gave 324 of aspirin and the nitro, and then put him on a little bit of oxygen. He was complaining of some shortness of breath. Repeated 12 leads in route, no changes. And I earned into Union Terre Haute with possible stimming. Arrived at the emergency department at 2:43. EKG again showing signs of stimming. Aspirin nitro had not done anything with pain. EMS or ER gave IV morphine, so ×2 in the emergency department. Ended up going to cardiac cath at 100% inclusion of the RCA, balloon stented down to 0% residual. We've been to the ICU and eventually discharged home. Door to reperfusion of 82 minutes, first medical contact 123. So highlights on this one, they did document their STEMI alert from the field. They did do a right-sided EKG, which I can tell you as chest pain coordinator for Clinton, this is going to be involved in all of the order sets at Union here as well, getting that right-sided EKG for inferior MIs to evaluate for right ventricular involvement. Repeated EKGs, monitoring for evolution on the way in. The big catch again on the erectile dysfunction medication. They did give nitroglycerin to this one after confirming right-sided ventricular involvement, which you can have a drastic decrease in blood pressure with that. In this particular case, the patient was in the 160s to 180s, so I'm guessing they just felt like benefit maybe outweighed the risk.
Went down with you.
Right, yeah. We're really at a risk of bottoming out at like 80 or something like that.
Thanks, Will. Anybody have any questions for Will? Appreciate it, Raymond. Tina, you ready? Tina Hedges is going to do our trauma report next. And we'll see if our speaker shows up or not.
9:30, you still got 10 minutes.
I can do this.
Okay. Good morning. We have 2 cases today. This first one, the 35-year-old male, he was an assault. 911 call came at 0:45, dispatched at 0:46, en route at 47. So we're on the scene at 0:1, departed at 0:110, and was at Union ER 1:15. I just called dispatch was a minute, dispatched en route was 1 minute, en route to arrival was, on scene was 4 minutes. On scene departure 9 minutes, departure to arrival ER was 5, and total time was 20 minutes from the call to arrival in ER. So the EMS report said that they were dispatched to a local bar for an injured person. They was reported they had agonal respirations. It was an altercation. He did have an alteration.
Did that problem.
Yeah, he did. He was struck multiple times with a pool stick. There was alcohol and closed pocket knife found by the patient. Police was on scene. He was unconscious and had irregular snoring respirations. He was bleeding from his head, looked to have approximately, their words, 1 liter of blood on the ground. He was unconscious and unresponsive. GCS, sorry about that, GCS was 3. He was placed in a C color. Several lacerations on the top and the back of his head was bleeding. One laceration showed his skull was visible through it. So they controlled it with ABD pads and Curlex. He had blood from his mouth. His dentures were broken, had significant bruising and swelling to his right eye. 2 small lacerations, the upper chest was bleeding, that was controlled. Snoring respirations, they were bagging him, then they were able to intubate him. Level 1 alert was called. So the pre-arrival note from here said unconscious, intubated, multiple lacerations, pulse ox was 84. Pulse was 81, 70 over 110 and 88. I believe that was after he was intubated. Level 1 trauma was called out at 0113. He got here at 0115. Pupils were dilated, 7 on the left, non-reactive on the right. Ocular pressures were done. It was on the left, it was 24, and the right was 26. Vitals in ER once they got him kind of stabilized a little more. 130 over 89, 83, 19, 93% on the vent. So this is our criteria for level 1. Sorry, I think it might be a little blurry. So he met for several criteria. It was intubated or assisted ventilations of a trauma patient, any signs of respiratory insufficiency, hypoxia, accessory muscle use, grunting, respiratory rate 10 to less than 10 or greater than 29, active or controlled hemorrhage of any source. He was bleeding from his head. GCS less than 8 with mechanism attributed to trauma, and his was 3. So he had multiple criteria that he met. Diagnosis, I'm not going to read word for word for every one of this, but basically he had right frontal parietal fractures that were significantly commuted and mildly depressed right frontal lobe or bone fracture. Frontal skull fracture went into the anterior posterior aspect of right frontal sinus. The fracture also involved the anterior cortex of the left frontal sinus, pneumospalus. Let's see, fractures extended through the bilateral orbital roof and bilateral orbital floors. Acute displaced left occipital skull fracture, acute unit right occipital skull fracture extending into the right occipital condyle size. Right temporal bone fracture, and it was commuted and it extended to the sphenoid sinus. I can't say those words, but he had more fractures, cribriform plate, was very high risk for CSF leak. Blood and fluid was filmed paranasal sinuses, subarachnoid hemorrhage in the right frontal area. He had frontal parietal subdural hematoma, largest in the right frontal, was 5 millimeters. Mass effect and some mild right to left shift was 3 millimeters, and then he had interconal hemorrhage in that right eye, and it goes on. Commuted fractures involving the frontal bones extended through, the frontal sinuses, ethmoid sinuses, commuted fractures, as well as the right sphenoid sinus, commuted fractures, right mandible or mandibular ramus, commuted fractures involving the zygomatic arch, parasinal sinuses were filled with blood, commuted nasal bone fractures, parasinus I can't, what, he had blood. He had a lot of blood. So basically, he had a lot of blood. So all of this, he pretty much broke all of this.
And some of that too.
And all that. Boom. I mean, they.
This was a pool cue, right? This was just a pool cue, right?
It was the, probably the fat end of a pool stick. I mean, they're solid. Yeah, so he had all of that broke. And for EMS to be able to get him intubated, I think was nothing short of a miracle and what actually skills on their part. I don't mean to shorten you guys. But I mean, and that had to be a very, very difficult intubation. So kudos to you guys. So yeah, he broke all that stuff.
Yeah.
So diagnosis, they've had, going on. Lung findings suggested pulmonary contusion, aspiration pneumonia, so they probably stomped on his chest pretty good. Then they did, CT of the neck and cervical spine and all that. So diagnosis was trauma, extensive facial fractures, bilateral, subdural and subarachnoid hemorrhage with a little bit of a shift. They did not do a drug screen here. He did get IV antibiotics and he was transferred to IU via ground because of weather. So any opportunities, I think they got him here like really in record time and for EMS to be able to intubate him, for us to get the work up. and
How old
get
did you
him-
say this patient was?
Oh,
35?
35, yeah.
Okay.
He's, I know him from a while and he's had a long history of drug and alcohol abuse and just kind of a difficult life, but just as a follow-up, I followed up on him about a month later and they were working on getting him placement because he had to have a crane, he had a trach, he had a peg. They were working on getting placement, but they couldn't decide whether long-term rehab or acute care or like an LTAC or acute care rehab, because he was following some commands, but it was intermittent and real slow. And then, when I was writing this up, I looked him up again because I honestly thought he probably died. And he actually got into an acute care rehab in Lafayette and went back to Methodist. That was like the end of February, end of March, or the middle of March, like the 13th. He went back to Methodist because he had hydrocephalus and it had gotten markedly worse. So they sent him back and he had a VP shot put in and was actually, his trach was out, his peg was out. He's eating, he's drinking, he's following some commands that I'm sure he'll never have a really good quality of life. But to his family, a life is a life. And they've got him and they're gonna take him home. They've got it all set up, so they're gonna take care of him, got the equipment to care for him at home. And they're probably gonna care for him the rest of his life. Yeah, so.
Amazing.
Yeah, and the pictures I passed out, those are Lafort fractures, or 1, 2, 3, and me and Jackie and was talking, you might see one or maybe a couple, but you very rarely, from my understanding, see all three. He had all three. So they literally fractured his whole face. He made somebody pretty angry, I think.
Yeah.
All right,
It's like-
so
Which that just speaks to the intubation skill too, if they
Yeah.
did that with a Lafort 3.
Yeah.
that's what I
Because
mean.
nothing is where it belongs.
Yeah, no.
That's what I were joking, Wilson, that means your face is coming off and it
Yeah,
literally.
no, I wasn't taking light of that
Yeah.
at all. It was literally.
Yeah, so
a
that
great
guy
deal of
was
skill for them to
on
be
point
able
that
to
day.
do. Yeah.
Trying to.
Did it say how many attempts they had?
It's all moving.
Did they get it on the first?
They got on the first attempt, didn't they?
Yes,
Yeah.
yes.
That's
And-
Yeah.
Yeah.
Yeah, so there's a whole call was so because like they got him there, they intubated that and there was. It sounded like with so much blood.
Bubbles.
And they were having to suction him, they kept getting all the blood out of him and got him tubed on the first attempt. So,
You must have found something pretty good.
yeah,
They didn't say that again.
he made somebody very, very good.
Whatever.
All right. Anything else? All right. So the second case, this is TS. This was just kind of interesting. A 34-year-old male with a motor vehicle crash. My fingers don't work sometimes. With ejection. The call, a 911 call came in at 8:55. He was dispatched to they were dispatched 8:55 en route 8:59 on the scene at 9:13. This happened over in Illinois. Left the scene at 9:38. He was at Union ED at 9:57. called dispatch 0, dispatched en route was 4, en route to arrival on the scene was 14 minutes, scene to departure was 25. And there's a reason for that. Departure to arrival in ED was 19. And then the total call time, or from the call to the arrival, was 62 minutes. They were over almost to Marshall. It was on 70, so it's very busy interstate. And it was an SUV and there were 6 passengers. So
Seven.
he was,
Seven.
or 6, was there 7? Was there
7.
5 kids?
5 kids under the age of 7.
I thought there was 4. There was 5 kids, the husband and wife.
Yep.
So there was a whole lot going on.
And he was the only
so-
one that did not have a seatbelt on.
Yeah, he was the only one that didn't have a seatbelt on. So there was a whole lot going on. So that kind of
They're all being
explains the delay. Jumped out the window. That explains the prolonged time for the call. So, the EMS reported the ejection and they were going about 70 miles an hour. They ran off the interstate embankment and rolled unknown times. Well, I guess what had happened was she was driving and there was a semi, it was changing lanes
Bad
suddenly.
weather
And
too.
yeah, and she went, yeah, in bad weather. And she went over to try to get away from the semi and got a little too close to the edge and off they went. So the passenger was unbuckled to assist with the kids, being frisky in the back, and the patient was the passenger in the front. He was ejected out of the passenger window. They found him supine in the field. He was alert and oriented.
Care ambulance.
No obvious deformities, but he did not have any sensation in his legs. Pain in his neck, he was complaining about. They put him in a seat collar, gave him, started an IV, gave him pain medicine. They called a level 1 trauma. Pre-arrival was motor vehicle collision with ejection, neck pain, lying outside the car, no feeling bilateral lower extremities. He arrived in ED at 11:03. Level 1 trauma was activated at 10:49. Complained of neck pain, numbness from the nipple line down. He was unable to move his lower extremities. He could not move, he couldn't feel anything, nothing. Fractal tone, his vitals were stable. GPS was 15. Level 1 trauma, with all the criteria, basically it was the mechanism of the injury and him actually having no sensation. So they knew this was a very, very serious. So the diagnosis, they did the regular labs. CT of the neck showed cervical spine fractures of C3, 6, and 7. There was that's actually not bad. There was a grade 1, how you say that, hydrolysis, something like that, of C6 relative to C7, causing mild, moderate central spine now narrowing. I mean, it was serious. I mean, it was so obvious. I could see it. I was like, uh-oh, it's bad if I can see it. CT spine, the fracture of subluxation of C6-7, disc space, 1.1 centimeter intralithiasis or whatever. I'll keep making it up till I get it right. C6 relative to C7 due to bilateral C6 faucet posterior element fractures. Displaced cortical avulsion is fracture of the C7 with the avulsed fracture fragment located anterior to the C7 vertebral body. Mild to moderate bony central spine canal narrowing due to the C6 fracture, whatever it was. Mildly displaced vertically oriented fracture involving the left C3 faucet. And then they did more CAT scans. The CT of the chest showed defined areas of ground glass density in the upper lobes, the apical regions, greater on the left, which they thought maybe was pulmonary contusion. And then the CT of thoracic spine showed acute, appearing minimal superior in-plate compression fractures of T9, T11, and questionably involving superior aspect of T8. So there's non-displaced horizontally oriented fractures through the mid T8 spinous process. So diagnosed motor vehicle crash, ejection, unrestrained passenger, C6-7 spinal cord injury, C3 faucet fracture, minimal superior or superficial abrasions. They placed an art line, gave him fentanyl. There was no airport transport or air transport due to weather, so they transferred him via ground EMS. So, I mean, it was just, he had nothing from his nipple line down. And I mean, just to look at him, you would have thought he was fine. Had a couple little scratches on him and that was it, but
So I will say I took all 7 irons.
yeah.
We did not know we were getting 7 patients and it got very confusing. And this was not a local EMS agency. It was one of the Illinois ones. They gave us the IHERN for patient 1 and they said, I have a second patient. Okay, cool. We can do 2. That's easy. And then all of a sudden I got 7. I had to find a second surgeon and 2 more nursing trauma teams. So if you know you have a multi-casualty, will you please tell us? Here we're kind of spoiled because dispatch calls us that day, we sent them out on. So that was the EMS.
Yeah, just to mention, the wife and the kids were all okay.
Yeah, everybody else was started.
So they loaded all 7 patients.
In
one-
2
one-
Okay.
Okay.
Mom and 5 kids came in one.
You have a place for me to sit.
Yeah. And dad came in the other one. Obviously, he was the more seriously injured, but we didn't know it at that point. And I just happened, I can't remember who the primary trauma was. I didn't remember the one they pushed up. Whoever it
I
was,
don't remember.
Dr. Reeves just happened to be standing there and I said, are you in general today? And he said, yeah. I said, guess what? You're up. So that just happened to work out. The earlier you can let us know, the more time we have to be prepped. We did fine. That is the other diversion, by the way. We couldn't remember what the second one was. It was that.
Yeah.
Because Reeves turned around and said, this is a multi-casualty. You should be on diversion. I said, "Thank you."
Ooh, there he is.
Hey, how you doing, man?
Okay. Yeah, you can give us a heads up. Greatly appreciate it.
Not too far. It's going.
Hey, guys, thank you very much, Tina. Prognosis on that guy's outcome. So you're gonna be paralyzed.
He actually, was starting to get a little bit of feeling back.
Okay.
They got him in the, they took him back to the where you're working.
So it was a little bit of a weird home life, like not quite Amish, not quite. But it was just a different. dynamic. So, yeah, you know, like we gave the kids iPads and you thought we had 3 eyes. I mean, they were just like, ooh, electronics and like. Fabulous stuff.
Thank you very much. Dr. Knapp is back from his emergency and will be up here in the presentation, so.
Yeah, if I can have many of you guys come as close as possible, because I'm just gonna be showing help, so interactive. Don't, please don't sit in the back. Someone calling if you sit in the back.
I can advance for you.
That'd be great. That'd be great. Yeah. So I'll tell you a little bit about myself. Please, guys, you're way too far away. I'm way in the front. Don't be shy.
I do need you to stand more this direction, that way that cameras. This is being live Zoom also, there are people out there too. Thank you, sir. Thank you
Yeah,
very much.
don't be shy. Please come all the way in the front row. I need the front row. Like the 4th row, come up to the front row, please. So I'm born and raised in Terre Haute. My parents were born and raised in Terre Haute. I was in Indianapolis for all my adult life. I did all my training there, but I came back. I got after we sold our private group in Indianapolis, Ascension. Enjoyed Providence Medical Group. It's my 11th year here, and feels like I never left. I should have done it 33 years ago when I started out of medical school. So I'm not just a coronary guy, I'm also a peripheral vascular interventionalist, as are all the cardiologists here that do coronary. We also do vascular, and we do structural valves also, and we do carotids and aortic aneurysms, but we're gonna just focus today just on the heart, just on the coronary arteries. And I brought some catheters and stents to show you here. That's why I wanted you to come up close so you can touch them and feel them while I'm talking, okay? So, yeah. This is the classic, guys, when you get called. This is the classic symptoms. A white male over 65 years old clutching his chest. Nobody's gonna miss that. This is called Levine sign. When you take a history, one of the most important things is, I don't want to hear chest pain or shortness of breath. That's easy. I want to hear, is it sharp, dull, achy? Is it angina or not angina? Anginal type chest discomfort is what's pictured with that visual and verbal explanation of this gentleman after eating a big meal. Blood gets taken away from the heart into the splanchnic and the stomach, gastric, and you get a steal phenomenon if you have an underlying coronary stenosis. Coronary stenosis referring to here in the heart. So when there's a lesion and you get blood taken away, you can get the lack of blood flow. We call that angina. That's the word I want to hear when you guys give report. This is patients having classic anginal type chest discomfort, the EKG, the vitals, the medicines, your call and report, and that helps us tremendously. As opposed to, oh, the patient's having sharp stabbing pain. It worsens when they take a big breath. They have coughing up sputum. They're vomiting blood. Okay, that's probably stomach, esophageal, maybe pneumonia, maybe pleuritis, maybe pericarditis. However, there's the big ones you don't want to miss. We already mentioned acute coronary syndrome. You don't want to miss that. Okay, STEMI, non-STEMI, unstable angina with EKG change. Number two, you do not want to miss pulmonary embolism. Okay, tends to be more shortness of breath, can be chest pain, can be pleuritic chest pains. Air dissection, classic. Into the middle of my chest, it feels like somebody's tearing something into my back, between my scapula. These are the buzzwords, or between my shoulder blades. These are the buzzwords a patient will say for air dissection. And they tend to have one arm has a different blood pressure. They have disparate blood pressures. Okay. Pneumothorax. You guys have probably seen this more in trauma, blunt or penetrating trauma. Deviated trachea, decreased breath sounds in one side, sharp pains, and it hurts like heck. Sometimes it could be a young, Marfanoid looking patient, spontaneous pneumothorax. We see that in the taller, skinnier patients, tend to be males. These are the four you don't want to miss. You miss these guys, the patient's got a good chance of going to die. If you miss a gallbladder, you miss musculoskeletal, you miss anxiety, you miss acid reflux, you miss peptic ulcer, these are probably not going to die. Okay, but you know, these are the big ones. You definitely remember that. Commit that to memory. Next slide, please. Now we're talking about just about the heart now. I'm gonna focus on the heart. Hot plaque. We're talking about unstable plaque. Okay. Not the passive one, that exertional angina every day. I walk 3 blocks, I get tightness in my chest, goes to my arm. Okay. And by the way, it doesn't have to be chest tightness. It can be shortness of breath, it can be jaw, back, neck, shoulder. I've seen even right arm, you classically left arm, but just because they don't have chest pain doesn't mean they don't have an acute coronary syndrome. Remember that. Just because they don't have chest pain doesn't mean it's not an acute coronary syndrome, PE, pneumothorax, or air dissection. They can present atypical. Next slide. Now, we'll go through a case. We'll go about 3 or 4 cases, then we'll open up for questions and answers. This is a 52-year-old meth head. And most cannabis abusers, most people that abuse meth, cocaine, heroin, most of them also smoke nicotine. We know nicotine's atherogenic as heck. I'm telling you, according to the Annals of Natural, methamphetamine abuse, cannabis abuse is atherogenic. I don't care what anybody says. I'm not being political. I'm not being blah, blah, blah. I'm just going to talk straight. Atherosclerosis can be induced by cannabis and meth. The #1 cause in the state of California of congestive heart failure is methamphetamine. #1. It's no longer coronary disease, no longer heart disease. And this patient used it. They say they quit a long time ago. He used 6 months ago. You can't always trust him, but presenting with substernal chest discomfort. While in the waiting room, the nurse reported the patient had a seizure. The reason the patient had a seizure because they're not getting blood flow to their brain because they're in ventricular fibrillation. And the patient got defibrillated. Electricity is the key. You got to give electricity to this one. Okay. And the blood pressure was restored to 90. No more pulselessness, what we call ROSC, return of spontaneous circulation. The heart rate's 120. Now, I share this with you. One of the most important physical finding you're going to have, especially in the ED, in the field, what are the vital signs? Okay. What are the vital signs? Heart rate and blood pressure. You say, well, yeah, heart rate's 120, blood pressure is 90. That's a problem, okay? Because the patient's having a reflex tachycardia to keep the blood pressure up. It's not a normal blood pressure. This is early cardiogenic shock. Next slide, please. And here's what the EKG showed. So I said, don't sit in the front row, I'm gonna call on you. Right? So back row.
I suck at EKG, so don't
Who
ask.
doesn't suck at EKGs? Raise your hand, who doesn't suck? Right, second row. Who doesn't suck at EKGs? STEMI. What kind of STEMI? Very good. STEMI.
Oh, don't go that far with
It's a STEMI. That's 3, 4, 5, and those correspond to the anterior leads. V3, 4, and 5. See the ST. Here's the J point right here. There's about 3 millimeters to 4 millimeters of, and this is 5 millimeters ST segment elevation. We call these tombstones. They look like tombstones. The patient's gonna die. You don't get them. It's not, yes, you got to do your protocol. I suspect you've got a protocol. You got to fill out paperwork, scoop and go. Okay, the faster you get them on the rate limiting step is getting this patient to the ED where they can risk assess them and get them on the cath lab table. Because if you're in the field, trying to do this, that, and the other, and trying to diagnose them and scoop them and go, and you're gonna have to burn rubber to get to the nearest tertiary care center that has a cath lab. Thrombolytics can work, but there's risk. And the standard of care today is PCI for anterior stemming. The other thing I want to impress upon you on this patient is this patient has tachycardia. That's a reflex tachycardia because they're getting ready to go into shock. There's a whole anterior wall. The whole anterior wall is ischemic. So the anterior wall, inferior wall is beating, the anterior wall is not going to beat, and it's a reflex tachycardia to maintain the blood pressure. That's the pearl I want to give you. Okay. So anterior stemming, tachycardia, inferior reciprocal changes, and it's extensive anterior lateral. It goes in the lateral leads 1 and L. So this is a big heart attack. Okay, next slide, please. This is unfortunately the patient didn't make it. Okay, ended up in the table. Okay, on the pathologist table. This is what the plaque looked like. Thin cap fibroatheroma, we call it TICFA. Ruptured plaque, the thrombus. This is that Bobby Knight angry plaque. Okay, plaque rupture with thrombus. That's pathophysiologically what it looks like. And I challenge you, that looks like a dark red thrombus right here. That is not just red thrombus, it's also platelet mediated. So you gotta give antiplatelets, that's aspirin with clopidogrel, which is Plavix, or ticagrelor, which is we can do that in the cath lab. You guys are usually given aspirin. And we also use heparin or enoxaparin. Heparin's better because you can turn it off and reverse it easier in the cath lab or the OR. The patient ends up on the OR. Next slide, please. Okay, I think in the interest of time, we'll skip a lot of this, but does the patient need amiodarone? Probably. Would they have VF? Yes, we give amiodarone. And you follow the ACLS protocol. The routine labs, you guys are, we really want to know what the hemoglobin, platelet count, renal function is, and potassium, especially when they go into VF, and magnesium. Okay. Of course, troponin, but it's not going to help us now. We got a diagnosis. You already called it anterior stemming. So we don't need the troponin. We do do the troponins typically, but we don't follow them serially as much as we used to. We already have the diagnosis. Echocardiogram helps if you have time, especially if you're worried about pericardial effusion or aortic root enlargement with aortic stenosis and or aortic insufficiency. And you pick that up on physical exam with your stethoscope. Okay. Does the patient need pressures? I think the patient needs to be in the cath lab, emergency cath, this one with the impending cardiogenic shock, so we can put what we call mechanical support, either an intra-aortic balloon pump or Impella CPS device. So I'll show that here in just a moment. Next slide, please. This is what the patient came with that LAD. You mentioned anterior stemming. You can see the 100% thrombotic occlusion with no flow in that LAD. Large amount of muscle in jeopardy right in the front of the heart. The LAD, left anterior descending coronary. Here's the catheter, wire across, balloon. In between these dots is a stent. And here's what the stent looks like. And you can see flow back down the artery. That's PCI, percutaneous coronary intervention. How many in the room have seen a cath, heart cardiac cath in the room? Show of hands.
I've been in one. And as a matter of fact, the interesting part about it is, Doc, it was 100% blockage in my LAD.
Was it acute or was it state?
I don't know. All I can tell you for sure, considering I was kind of half out of it at the time, was that all I had in the amount of thing was just a little twinge in between my shoulder blades, and that was it. Not even remote pain, nothing.
So more atypical angina presentation.
Yeah.
Acute motor syndrome. Okay, that's a great testimony.
It's like, it's great. It was crazy.
So this is what we pulled out, thrombus. We used that export catheter. That's what that red clot. And I mentioned, it's not just red, it's also, you got to treat the antiplatelets. Okay, next slide, please. And this is what the deflated balloon crypt stent looks like. And then once we inflate the balloon, we release the balloon down, pull the balloon out, and the stent stays open. It's like Chinese.
Let's find some medicated.
Yeah, and drug eluting. Yeah,
Yeah.
The current since 20 about 2000, we started using drug eluting stents. Yep. Here's what a couple look like. I'll let you pass them around there. What a stent looks like.
Yeah, interesting. I've seen that.
And there's several alloys. Some are stainless steel. The newer ones are nitinol, titanium combinations with drug eluting. We have the best one here at Union Hospital and Regional. It's a Onyx Frontier. The newest version is the 6th generation. It's like sixth generation. Yeah,
Okay.
advanced, and you use the good stuff up front, you save money because the less strong nurses don't have to take any platelets as long, and better outcomes. Better outcomes means saves the hospital system money. This is what a balloon pump looks like, and the concept of a balloon pump is you augment diastolic flow in the coronary field. And that's what helps infuse the heart when you have cardiogenic shock, which what this patient got. And this is the concept of a balloon pump. Just a. That's performed in the cath lab under fluoroscopy. Next slide, please. Okay, any questions about the first case? Next case, 64-year-old white female with coronary disease, status post coronary arterial bypass grafting on three-way bypass in 2014.
Yes.
Complaining of classic substernal anginal type chest discomfort 3 hours prior to arrival at the ER at Union Hospital. Patient quit meds, stops because they thought they were, once they had bypassed, thought they were cured. But we still remember, we still need to give the patient antiplatelet agents, statins, beta blockers, ACE or ARB. That's the basic four that you need to take to prevent a future major adverse cardiac or cardiovascular, cerebral vascular event. Patient's still smoking, that's very important. And you gotta take a history now. You gotta ask about cannabis, and meth, and any illicit drugs because they're atherogenic. Next slide, please. So who's in the front row? You guys are good at STEMs.
Yeah.
Go ahead and read that. First thing you do, always look at the name and the date. We eliminated the name and the date, but our friend old Dr. Chusey, she was in the ED that day, and she called me and asked her, needs help. What's first and the second thing you do after name and date, you find the P-way. P, QRST. And then I'll challenge you, there's a P-way buried in here. P, QRST. So you got 2-to-1 AV block. That's an extremely long pure interval. And the reason the patients have a high degree AV block is why, guys. Why is this? Front row. Anybody? Inferior ST segment elevation, 2, 3, and F, with high lateral reciprocal changes here in B1, B2. Your rigs have EKGs, guys?
Right.
Okay. But you, and what's the standard for interpretation in the field? Do they fax it electronically or?
Well, they transmit it either via the Zoll or through eBridge, the app, so we've got,
And who reads it?
usually they send it to these, they send it in, read by ER, and should be sent to you guys for
Good deal.
confirmation.
Good deal.
And then we should, hopefully, we're not even stopping in the ER, keep from and go straight to cath
Yeah,
lab. That's our
we're
goal.
Open, yeah, that's
Yeah, we understand that
and
part.
efficient
We have
time.
a really good process in place if you're not here, if it's after hours.
Yeah.
They're really great about getting it to us quickly, and then our docs are good about saying, yes, activate. So a lot of times the CAP team is here, sometimes simultaneously.
Time is muscle.
Yeah.
Okay. It's not, we're not trying to be rude on the medical side in the cath lab. Let's go, guys. And sometimes you want to fill out your paperwork and have it all done. Sometimes we gotta be resourceful and accommodate and overcome all the adversity. And there is adversity. And when you've done it many times over and over, everybody has a role and we know to respect each other, even though we don't talk or we're focused. Some people can't have to do one task at a time. Some people multitask. Some can handle adversity, some can't. These are the role play and the simulation I think we need to do. Like, that's why we're doing these cases. Have chalk and get feedback. And please make it interactive. Okay, so inferior STEMI, burn rubber to the nearest tertiary care center. In this Vigo County or the contiguous counties, it would be regional or union. What makes a difference where you go to regional or union? How do you guys decide?
Proximity and patient choice mostly.
It's location, isn't it?
Well,
Well, if
Yeah.
it's, I mean, if it's a life threatening thing, you have to
Yeah.
go to the nearest one, right?
nearest one, no matter what.
Next slide. And once again, angry Bobby Knight plaque, ruptured plaque. There's the thin cap. It's a fibroatheroma and it ruptured and went into the thrombus ruptured. And that's what this patient died to. We're over to today. Next slide, please.
They don't always know.
Next slide, please. So, yeah, you're good. We want to get that patient to the cath lab, okay? And this patient had previous CABG. You can see it was a bypass graft. Here's the median sternotomy wires. And this is the bypass graft to the right. You can see the 100% thrombus there. And next slide, please. And you can see that we did thrombectomy with the Mr. Clean device. took out the thrombus, manually aspirated, put a wire down with a balloon and stent, and you can see this red line, how we stented the segment. So no flow, good flow. Why they pay supplying this atherosclerotic right coronary artery. Next slide, please. The stent again. I think you have an example of the stent. The next slide, please. This is Impella. When a patient gets in trouble and we need to put a pump in, this is what an Impella looks like. It's a different kind of balloon pump. It goes into the ventricle. It gets more cardiac output. I brought some new balloons from my old one. It gets beat up here. So this is what a balloon looks like. Just a balloon. Okay. So go ahead and pass this around. That's a coronary balloon that's not been used. Okay. And then I'll start in the back. This is that's just the balloon. This is a stent on a balloon. This one out. That's some examples of this. Here. It's not drug coated. It's just polyethylene glycol. It's a plastic balloon that we open up that get the artery open, and then when we put the metal in, we mount the stent on a balloon. Oh, good.
Oh, sorry.
Careful.
Stent's mounted on there. Pass this around. Very creative. Next slide, please. So this is a 60-year-old white male, multiple cardiac risk factors, display of substernal chest. Vital signs are stable. So you hear the word chest pain. You want to ask those questions. What kind of chest pain? Character, position, radiation, associated factors, how long it's been there. Have they had this before? Have they had a previous heart history? What medications? That's what you're doing at the same time while you're hooking on the EKG, putting IV in, putting oxygen on. Next slide. Okay, so
Bounces.
guys, I think it's important to get updated on your EKGs, brush up on your EKG skills. Okay? First thing, look at the name and the date. Second, find the P wave. Okay, and you can see this patient, PQRST, PQRST. So that's sinus rhythm. Okay, ST segment, having chest. This is 2, 3.5. That's inferior. 5, V5, V6. That's an inferior lateral STEMI. Okay. So once again, burn rubber, the nearest tertiary care center, in the Vigo County or contiguous areas of the Union or region. Next slide, please. And this patient had emergent cardiac cath, get them on the table. You're not going to help them by taking extra time in the field, not going to help them by sitting in the ED. Because when you guys transmit the EKG and you notify this ED, that gets the other, you see, it's like passing a ball in basketball. You lead the pass. You don't throw the ball at the runner or the person streaking down the court. You lead them, throw it ahead of them. That way it takes, a minimum 30 minutes to get the cath lab team in. Let the ER know because they might be having another issue going on, staffing or room availability. They want to be prepared. That way that patient can easily flow and time is muscle. So getting that patient on the cath table is key. You can see this patient had a left circumflex lesions, and this was the infraculated artery, the distal RCA, and there's a tight lesion here in the RCA, but the distal lesion is included. Next slide, please. And the patient got a stent, and I think passing around those stents, you can kind of get a visual and verbal experience on seeing what it looks like, how it's applied, and the technologies and the little tubes we go through. Next slide, please. We're going to go ahead and stop there. And I'll go ahead and open it up for questions and answers.
So just so you know, our process is they do call in a stimulator. We have a eBridge, which is an app that ties into our iHearn. So they can get pictures, they get those things.
100% on every rig.
Yeah. Yeah, it's available on every rig. It's available on every rig, yeah.
Okay, because I think last time I gave this similar lecture, we were up in North Terre Haute, and not every rig was working right.
The app is available for
The app
every
is
rig.
available, but not every rig.
Some
has
of
it.
them are not utilizing them like we.
So not
We're
every
working on it.
potential chest pain patient that you see in the field has that.
Sure.
So I had a patient was in Reelsville, Indiana. The medics went there. Reelsville. Where the heck Reelsville is?
Over on the other side of Brazil.
East of Brazil.
They skipped St. Vincent Clay and came
So
straight
that is
here.
very common.
Yeah.
Yeah, but
St. Vincent Clay will tell them to skip them.
But they didn't go St. Vincent Clay.
No, they usually just go
It
around.
really saved a lot of time.
I'm sure.
Come on up here, guys. Maybe we'll, come on up here, everybody.
Are you done, Dr. Nassar? I'm gonna go ahead
Yeah.
and stop recording
Yes,
this and
please.
stuff. So, hey, guys, everybody, a couple things I need you to think about out online there.
20% of patients have a normal.
you know what's funny about that is that's when I learned that you can't do atypical chest pain
Okay.
on myself.
Oh my gosh.
From here, just want to remind everybody about our EMS Skills Days on September 5th, 6th, 7th, and 8th.
Touch it.
All 4 days will be 9 to noon. At the Resimulation Center, you will be able to knock out all your skills required for every 2 years on one of these 4 days. Half hour, and you'll have them all done.
The catheter. That's a.
EMS week luncheon, actually, the date changed. We had set it up for the 17th. It's actually gonna be the 24th. 11 to 1. The mayor will be there at about 11:30 to do the proclamation. There'll be gifts, EMS gifts, food from Rick's. Carroll Fire Department's gonna be producing the drink, gonna be giving the drinks. Transcare's gonna be doing the desserts. Gonna be giveaways, gift, EMS gifts, of course, from Union Hospital. Also additionally to that, there'll be some gift cards giveaway. Regional and Union will both be doing that. Just want to make sure everybody understands that. And then I have the EMS conference, by the way. EMS conference is on the 18th of May at the Lansbom Center. It's an all-day thing. You're gonna have 8 hours of continuing education for free. Plus breakfast and lunch will be provided. So please go out on Eventbrite. There's the link here. Please go out on Eventbrite and sign up. Like I said, it's free. It's gonna say buy a ticket, but the ticket doesn't cost you anything. I think I have about 17 people in there now. I'm asking everybody to try to fill this place up. I'd like to get 40, 50 people. That'd be really amazing. We have Dr. Yazel coming from the state of Indiana, our state EMS medical director, is gonna be doing the keynote speak. Muhammad's speaking, Dr. Lynch is speaking. Got a neuro from Goodman Campbell. We got quite a few people doing some good talks, so want to bring that up. And then the last thing is, if you want credit for the April A&R, unless you were in the building, there's the scan, you can scan this, or there's the link to take the quiz. The quiz should have your name, your email address, what service you're with, and then a few questions that I built in there. All right, so please jump all over this.
One like that's gonna be a bigger
Yep.
gauge as well.
So with any other questions I've got, Brian, you got something? This Friday, at Hospital's gonna be hosting grand rounds with a burn talk on Friday at 11.
Yeah, it's specifically geared for Free Hospital. Dr. Krantz, our trauma director, is going to be speaking on that, and it's a very interesting presentation, especially folks in EMS. This is kind of really geared in your direction. So
We got newer.
feel free to drop by. I believe there's, if you need the link, I think I've got a WebEx link. I think Barry does too for that, or you know, that you can get
I
online.
really like.
So if you aren't no other questions, holler at me, text me, let me know that you were on. I'll get you on the sign-in sheet. If you haven't signed in, please go out, take the quiz, and I'll know that you're on there too. For not any questions, I'm going to stop this and close it out. Thanks so much for everything. Appreciate it.
How we access right here. Use needle.